I'm a pharmacist. I've reviewed the medication lists of thousands of seniors, and I can tell you this. Right now, the medicine in your cabinet, the pills you trust to make you better, might actually be the reason you fall. Today, I'm going to show you which ones, why it happens, and what to do about it. Let me paint a picture. You've been taking the same blood pressure pill for 10 years. Your doctor said it was safe. Your pharmacy is filled with names you recognize. Trusted medications for your heart, your sleep, your mood, your pain. So one Tuesday morning, you're making coffee. You stand up maybe a little too fast. The room spins. Your balance is just off. You reach for the counter. You make it. But what if you hadn't? What if that moment turned into a fall, a fracture, a trip to the ER, a summer you couldn't walk in your garden? And here's what your doctor might not have told you. Most of us think falls happen because we're clumsy, or weak, or just getting older. It's a normal part of aging, right? Wrong. And that's where the healthcare system has misled millions of seniors. The real villain isn't age itself. It's what we're prescribing during these years. And it's not that newer pills are inherently bad. They're often safer than the drugs we used decades ago. But here's what makes them dangerous for your aging body. When you turn 70, your kidneys and liver can't process drugs the way a 40-year-old's can. The same dose that was safe for you at 50? It builds up. It accumulates. Compound that with taking multiple medications. The average senior takes 4 to 5 different drugs. And suddenly your body is swimming in a chemical cocktail that was never intended for that dosage level. And that's when the falling starts. The root cause isn't the pills. It's the mismatch between how we prescribe, using one-size-fits-all doses, and how aging bodies work. It comes down to 3 things: how much medication, which type, and when you take it. Now, let me be clear. I'm not saying stop taking your medications. That would be reckless. But I am saying the CDC, the American Geriatric Society, and major research institutions have all flagged a serious problem. Between 1999 and 2017, prescriptions for fall-risk medications in seniors skyrocketed. At the same time, deaths from falls more than doubled. That's not coincidence. And here's what most people don't realize. There are 10 major drug classes that increase fall risk. Most of you are probably taking at least one, maybe 2 or 3. But which ones should you worry about most? That's what we're diving into next. If you're currently taking any of the medications we talk about today, do not stop taking them without talking to your doctor. Stopping suddenly can cause serious withdrawal symptoms. But by the end of this video, you'll know the conversation to have. So keep watching. Stick with me. Because of the number 5 medication we talk about, hospitals have completely redesigned protocols around it because of how dangerous it is for falling, and it's probably in your medicine cabinet right now. Let's start with the most commonly prescribed blood pressure medications, or antihypertensives. Over 50% of seniors take one, and they're necessary. They prevent stroke and heart disease. But here's the catch. These drugs work by widening blood vessels and reducing the force of your heartbeat. That's good for your blood vessels, but bad for your balance. When you stand up, gravity naturally pulls blood away from your brain for a moment. In a young person, the body compensates instantly. In someone taking a blood pressure pill, that compensation is slower. You get a split second of dizziness, orthostatic hypotension we call it. Your blood pressure drops when you go from sitting to standing. Picture this. 78-year-old Margaret has been on Lisinopril for 5 years. One Saturday, she gets up from her reading chair to answer the phone. She stands. The room tilts. She feels for the armrest, but misses it. She falls, fractures her wrist. 3 months of physical therapy. And it started with a blood pressure pill. The mechanism? The drug was working perfectly. It lowered her blood pressure, but at 78, with slower reflexes, her body couldn't adapt fast enough. Now, here's the thing. Blood pressure pills are often necessary. The key is which blood pressure pill and at what dose. Some are riskier than others for falls. Alpha blockers like doxazocin are high risk. Certain diuretics, they can deplete electrolytes, making the dizziness worse. The message isn't stop taking your blood pressure pill. It's ask your doctor if you're on the riskiest type and whether it can be adjusted or switched. But blood pressure pills are just the beginning. The next one, it's taken by 1 in 8 seniors. Antidepressants, prescribed to 1 in 8 seniors over 65. And I get it. Depression is real, and these drugs can be life-saving. The problem? They were designed for working-age adults, not people in their 70s and 80s. Here's how they increase fall risk. Antidepressants affect balance directly. Some types, especially older ones called tricyclic antidepressants, block a chemical in your brain called acetylcholine. This creates what we call anticholinergic burden. Basically, your brain's coordination system gets sluggish. You move more slowly. Your reaction time slows. And cognitively, they can make you feel foggy. The newer ones, SSRIs like Sertraline, are safer in some ways, but they can still cause dizziness and orthostatic hypotension. Remember that blood pressure drop we just talked about? Double the risk if you're on both a blood pressure pill and an antidepressant. Real scenario. 82-year-old Robert started Sertraline for anxiety 2 years ago. His doctor never mentioned fall risk. Last month, he was walking to the mailbox. He felt slightly dizzy, a familiar sensation by then, but it had become his normal. This time, he stepped wrong, twisted his ankle, sprained ligaments, couldn't walk for 6 weeks. He attributed it to bad luck. It was actually a medication interaction he didn't know he had. Depression is serious, and these medications often prevent worse outcomes. The solution isn't to stop them, it's to 1. Determine which type you're on. Are you on the older tricyclics or the newer SSRIs? 2. Check if you can lower the dose. And 3. Ask about non-medication alternatives like therapy or CBT, which we'll cover later. Now, those are medications people understand are affecting their mood. But the next one? Most seniors take it thinking it's helping them sleep. It's actually making them unstable. This is a big one. Z drugs, Zolpidem, Azopiclone, Zaloplan, are prescribed to help people sleep, and in the short term, they do. You take a pill, you fall asleep. Sounds simple, but here's the problem. These drugs are designed for 8 hours of sleep in a young adult. A senior's body processes them much more slowly, so when you wake up at 6 a.m., the drug is still in your system, still working, still sedating your brain. That grogginess you feel in the morning? That's not just being tired, that's a medication still suppressing your central nervous system. And while you're groggy, you're also less coordinated, less aware of your feet and legs. What we call proprioception. You shuffle. You don't pick your feet up as high. You're more likely to catch your toe on the edge of a rug or a step. And here's where it gets dangerous. The same low blood pressure drop we saw with blood pressure pills. Z drugs make it worse. You're dizzy, you're uncoordinated, and your body can't react quickly if you start to stumble. Clinical example, 75-year-old Susan takes Zolpidem every night. She's been on it for years. One morning, still groggy, she walks to the bathroom in the dark. Her balance is off. She misjudges where the toilet is, a common thing with grogginess, and falls into the shower stall. Broken collarbone. 6 weeks in a sling. She told her family it was just an accident. It was actually a predictable outcome of a medication her body couldn't clear overnight. Now, some people genuinely struggle with insomnia, and I'm not saying never take a sleep aid. But here's what the research actually shows. CBT for insomnia, cognitive behavioral therapy for insomnia, is more effective long-term, has 0 fall risk, and most insurance covers it. So the conversation should be, can I try CBT-I first? And if I do need a medication, is there a shorter acting version, or can I take it earlier in the evening? And we're still just at the top 3, because the next one is prescribed for pain. And if you have chronic pain, you probably know it well. Benzodiazepines are some of the most prescribed and most dangerous medications for fall risk in seniors. These drugs work by slowing down your entire nervous system, your brain, your reflexes, your muscle tone. They're intended for short-term anxiety relief, but many seniors have been on them for years, sometimes decades. And here's why they're so dangerous for falls. They don't just make you calm, they make you weak. Your muscles literally lose tone. Your reaction time slows dramatically. And cognitively, you become less aware of your body and space. It's like trying to walk through water. You're moving, but everything feels slow and effortful. Combine that with the blood pressure drop we talked about, or the grogginess from a sleep aid, and you're in a perfect storm. The really scary part? The FDA issued a boxed warning, their strongest warning, for combining benzodiazepines with opioid pain medications. Together, they can cause profound sedation, respiratory depression, and even death. And yet many seniors are prescribed both without being told they're taking a dangerous combination. Real case, 79-year-old Michael has been taking Lorazepam for anxiety for 12 years. His doctor prescribed it, and he's never questioned it. He also has arthritis pain, so he takes Hydrocodone as needed. One evening, he takes both. The next morning, he's so groggy he can barely open his eyes. He shuffles to the kitchen, doesn't see his cat, steps on the cat, loses his balance, and falls down 3 stairs. Broken ribs. His medications were individually prescribed by different doctors. Neither doctor knew about the other. But together, they created a fall waiting to happen. If you've been on a benzodiazepine for years, I'm not saying stop today. These drugs have real dependence potential. Stopping suddenly can cause seizures, but you should have a conversation with your doctor about 1. Can this be tapered down slowly? 2. Is there a specific reason I still need this? 3. Are there alternatives? The goal is a gradual deprescribing process, supervised by a healthcare provider. Now, those are all serious, but the #1 medication that increases fall risk? It's the one that's designed to relieve pain, and nearly 1 in 5 seniors are taking it. Opioids. These are prescribed for pain management, arthritis, back pain, post-surgical recovery, cancer pain. And for severe pain, they can provide real relief, but they are extraordinarily dangerous for falls in older adults. Here's why. Opioids sedate the central nervous system in a very specific way. They don't just make you drowsy. They impair your judgment about your own balance. You feel fine. You think you can walk without support. But your coordination is actually impaired. You move slowly. Your reaction time is shot. And crucially, opioids can cause orthostatic hypotension, that blood pressure drop again, and respiratory depression, meaning you're breathing more shallowly, getting less oxygen to your brain, which makes everything worse. I mentioned earlier that the FDA issued a boxed warning for opioids combined with benzodiazepines. Here's the clinical reality. Seniors taking this combination are at astronomical risk for falls, overdose, and death. And yet, it's not uncommon. A real case that still haunts me. 71-year-old Dorothy had arthritis. Her doctor prescribed oxycodone for pain. She also had anxiety from years of health issues and took alprazolam. Neither doctor coordinated. One afternoon, she's watching TV, decides to get up to answer the phone. She stands. She feels okay. The opioid makes her feel better than she does, so she thinks she's fine. But her balance is actually significantly impaired. She takes 2 steps, she staggers, she falls against the coffee table, hits her head, subdural hematoma. She died 3 weeks later from complications of that fall. Her family said, "She just fell. It was bad luck." But it was actually a predictable consequence of a medication interaction no one had warned her about. I need to say this clearly. If you're taking an opioid and a benzodiazepine together, you are in an extremely high-risk category. According to the FDA's own data, this combination accounts for a significant proportion of opioid-related overdose deaths and serious injuries in older adults. Talk to your doctor this week, not next month, this week. So we've covered the top 5, but I promised you there's more hope than just don't take your meds. Let's talk about what does work. Here's what the research shows, and this might surprise you. Some of the most effective ways to prevent medication-related falls don't involve medications at all. First, physical therapy and balance training. Studies show that targeted exercises, specifically balance and strength training, reduce fall risk by up to 50%, even in people on high-risk medications. You don't need a gym. You need someone teaching you the right moves: single leg stands, heel-to-toe walks, chair squats. Many insurance plans cover PT if your doctor prescribes it. Second, CBT for insomnia. If you're on a sleep aid, CBT-I is more effective than Zolpidem for long-term sleep improvement with zero fall risk. It retrains your sleep-wake cycle. Most insurance covers it. Third, therapy for anxiety and depression. Psychotherapy, or combined psychotherapy and low-dose medication, is often more effective than medication alone for anxiety and depression, and it has zero fall risk. Talk to your doctor about a referral. Fourth, pain management alternatives. For pain, PT, topical creams like capsaicin or lidocaine, acupuncture, and even mindfulness meditation have strong evidence. They don't have to be your only approach, but they can often reduce how much medication you need. Fifth, home safety. This is huge. Remove tripping hazards. Install grab bars in the bathroom. Make sure your home is well lit. This doesn't require a prescription, and it works. The key insight: your medications are part of the solution to your health problems. But they're not all of it. A comprehensive approach, medication review, plus physical therapy, plus home safety, plus non-drug stress management, is far more effective than any single intervention. So what do you actually do with this information? Well, here's your action plan. Step 1. Make a list. Gather all your medications, prescriptions, over-the-counter, vitamins, supplements. Write down the name, the dose, and why you're taking it. Step 2. Schedule a medication review. Call your doctor or pharmacist. Say, "I want a medication review. I'm concerned about fall risk." Most appointments are 20 to 30 minutes long. Step 3. Bring a list of questions. Could any of these medications increase my fall risk? Are there safer alternatives? Can we reduce the dose or stop anything? What non-medication options are available for my conditions? Step 4. Don't stop anything on your own. Work with your doctor on a plan. Step 5. Implement the non-drug changes. Start PT. Improve home safety. Pursue CBT-I or therapy if relevant. The result? You'll likely take fewer medications, have fewer falls, and actually feel better. Falls are not inevitable. They're not a normal part of aging. They're a preventable consequence of specific modifiable factors, and you have more power over your health than you might think. Here's what I need from you. First, check your medicine cabinet. Look at your list of medications and be honest with yourself. Are any of them ones we talked about? If so, you now know what to look for. Second, comment below. Tell me, did you recognize any of these medications in your own regimen? And more importantly, have you ever noticed dizziness or unsteadiness after starting a new medication? Your story might help another senior recognize their own situation. Third, save this video, literally. Use the save or bookmark button. Keep it handy for your medication review appointment. Show it to your doctor. Fourth, share with someone who needs it. If you have a parent, a friend, a neighbor who takes multiple medications, send this to them. One person's awareness might prevent another person's fall. And fifth, subscribe. Because we're going to keep bringing you evidence-based health information that actually matters for living your best life, not clickbait wellness nonsense. This is your health, your independence, your right to keep doing the things you love. Medication management isn't sexy or exciting, but it might be the single most important conversation you have this month. Take care of yourself. You're worth it. Until next time.